Hello and welcome to my presentation this morning. Today I'll be discussing how the emergency youth shelter system and health system engage to coordinate care for the health needs of youth experiencing homelessness in Toronto. I will start by providing some background on my topic. I will then provide an overview of my research question and research objectives. I will then discuss the methods I use to respond to my research question, as well as the findings that have come of my research so far. I will then share some recommendations from the key informants I've had a pleasure of speaking with. And finally, I will share a short summary of the presentation, some next steps in my research, and some closing remarks. So to start, we know that youth homelessness results from a complex interplay between structural factors, individual and relational factors, and systems failures. Systems failures often occur as a result of inadequate public policy or service delivery, which put youth at being risk of homeless. Many youth end up slipping through the cracks of these public systems, especially when they face crises or are transitioning between systems. This is especially true in the case of transitioning between the health system and the youth shelter system. Poor coordination of care between these systems results in youth losing their beds at the shelter that they stay at sometimes, and also losing continuation of care for their health needs. As a result of these fragmented services and poor coordination of care, we know that there is a need for an integrated systems approach to care for this population. This is defined as the coordinated delivery of individual services within and or across different sectors, vertically within different agencies, and or horizontally between different agencies. In the organizational response to homelessness, this is often used synonymously with coordination of care. And so I will be referring to systems integration as coordination of care in this presentation. My research question is, how do the emergency youth shelter system and health system engage to coordinate care for youth experiencing homelessness in Toronto? There's a large body of evidence which indicates that there is poor coordination of health service delivery between these two systems. However, there is also a lack of evidence on what this coordination of care process looks like between these systems. We also know that improving coordination of care will likely help to improve youth health and social outcomes. So my research aims to really understand what these processes look like, what the gaps in these processes are, and how we can target these gaps to make meaningful change down the road. In this presentation, I'll be discussing my preliminary findings from 8 key informants. The purpose of sharing my findings is really because I think that they're timely and relevant, especially now, and I think they may be useful to those who work in the sector. In the presentation, I'll be discussing processes of coordinating care between these two systems, some gaps, challenges, and inconsistencies in these processes, as well as some strong points, and finally, some recommendations from informants on how these processes can be improved. I've used a systems thinking approach in my research. It's also grounded in grounded theory methodology. The overall study is a multi-method qualitative one. However, for the purpose of this presentation, I have focused my findings on the key informant interviews that I've conducted and analyzed. In the study, I have used both purposive and snowball sampling. And so far, I've had a chance to speak to informants who work within the emergency youth shelter system mostly. So this includes management and executive staff, clinical and non-clinical frontline staff, as well as folks from the City of Toronto. What I found is that the processes of coordinating care are quite inconsistent across shelters, and this can be because of the varied capacity that each shelter has based on their funding, the human resources that they have. Some shelters have clinical staff on site more regularly than others, and each shelter also has a different relationship with different community-based and health-based organizations in their community. I also found that there are no specific policies internally or through the city on what this process of coordinating care should look like between systems. I also found that there is no specific training specifically for coordination of care on site at shelters for frontline staff. Staff mentioned receiving training for first aid, for using a trauma-informed approach to care, as well as case management, but nothing specific to coordination of care. When analyzing my findings, I found that key informants spoke about the process of coordinating care on site, as well as when referring youth to external institutions and agencies. I also found that they spoke about how the process looks different for emergency situations and non-emergency situations. And in making sense of my data, I found it best to organize it in this way. So first, if there is a clinic on site, then, or not just a clinic, but if there is healthcare on site, whether it's physical or mental health care, then youth have access to that care quite readily. If that healthcare is not provided on site or not accessible on site, then the case manager, youth worker, or healthcare provider will complete an assessment for the youth and then refer them to an agency or organization that will meet their healthcare need. After a waiting period, the youth will hopefully get an appointment and then receive access to the care that they need. In the case of an emergency, staff will either call EMS or police. If they call EMS, they will arrive to the shelter and then escort the youth to the hospital. And then at the hospital, either the youth will be there for a specific period of time, usually not too long, and they will return back to the shelter, or shelter staff will be tasked with following up with the hospital staff to get some important information, mostly just to know when the youth will return back to the shelter. In non-emergency situations, a referral is made to an external organization, and then the youth will either receive the public health service that they need, so perhaps appointment with a family doctor, or private health services such as eye care or dental care. Some challenges to these processes include challenges with follow-up, inconsistencies in policies and protocols between systems, but also within systems, fragmented communication between shelter staff and healthcare staff, privacy and information sharing policies, which have posed as barriers in providing or facilitating that continuous care once youth returns to shelter, a lack of resources and funding, and finally, the hospital setting sometimes being triggering for youth, usually due to past experiences that have been negative. Many of these challenges overlap with each other, so I'll just share some direct examples that key informants have shared with me. So the first here is around fragmented communication and information sharing policies acting as a barrier. This team lead at a shelter says that there is a lack of communication between different levels of care. Most times the youth will return to shelters without discharge papers. There's no communication with hospital staff. And she feels that there's just so many hoops that she has to jump through to find out what happened at the hospital. The second example demonstrates the uninviting hospital environment, and again, some challenges with follow-up. And this is one example that has come up repeatedly in my interviews. One staff at the shelter says that when they send youth to the hospital, healthcare providers at the hospital simply check vital signs, ask the youth, "Are you okay?" The youth responds, "I'm fine," and then they are back to the shelter, and this back and forth between both systems continues without really addressing the healthcare issue that the youth is facing. Another staff member has said that the youth enters the hospital, they sort of get lost. It's a big place, it's daunting, it's scary, and it can be a stigmatizing experience. In these two examples, we see the barrier or the challenge a lack of resources and lack of funding can pose in the coordination of care process. One person has said here that they don't think there are enough mental health and addiction supports built into the shelter system in Toronto. And even though this shelter they have a clinic, they still feel that there aren't enough mental health and addiction supports. And what they do have is through self-funding. In the second example here, we see that even with private health services, they're not readily available, they're hard to access. And this person argues that they don't have the capacity to find funding to afford this type of care. So it becomes really hard for staff at the shelter to coordinate some of these services for their youth. And finally, with the inconsistencies within systems, we see that sometimes shelter staff will be able to speak to hospital staff, get an update. Other times, hospital staff will not share information with them because of their own training and their own policy. So she says here, different hospitals get different training, and also another inconsistency is around approaches to care. When two organizations who are caring for the same population don't have the same approach to care, that can often also pose as a barrier to coordinating care for this population. Some strong points that came up were around relationships, both between system staff and health system staff and youth shelter staff, but also trusting relationships that are built with the youth. Another strong point that was mentioned is the presence of a youth worker at a hospital who's there to support the youth while they receive care, but also to provide relevant information to their case manager. And lastly, having health services on site is also quite helpful. So here we see that a shelter that recently received a mental or recently recruited a mental health team found that it's been really handy to have on site. Youth don't have to wait for an appointment. They can meet with their healthcare providers on a more casual basis. In the second example, we see that when staff are able to build trusting relationships with youth are more comfortable accessing care at the hospital. And they're not imagining the worst case scenario that they think might be, that the hospital visit might be. The presence of a youth worker also makes coordinating care more timely and seamless. This one person mentioned having a relationship with a youth worker at St. Mike's who follows up with them, who provides them with the discharge summaries. And this has also really helped in knowing what type of continuation of care is required for the young person. And lastly, having relationships with system staff whose mission statements are similar, whose mandates are similar, also helps in building those networks and providing and coordinating care more easily for the youth. Some ideas for improvement that were mentioned were to, one, have more human resources available on site, so including healthcare providers. Two, being consistent in approaches to providing care, but also coordinating care, both within and between systems. Three, increasing and improving communication between system staff. Four, having more youth and transition workers on site at the hospitals to support the youth, but also provide information and follow-up support to shelter staff. Have more training available for staff on processes of coordinating care. Six, having more strategic partnerships between systems. So the inner city health associates was one that was mentioned time and time again. So having more partnerships such as that one. 8, accessing medical records all in one place. And 9, adjusting privacy policies to improve quality of care at the shelters. So in summary, there is quite a bit that needs to be done at various levels of both systems, and I hope to be able to share some more detail around how, as stakeholders, we can do this, or how we can be advocates for this kind of change once I have completed my research. And if you're interested, I hope that we can connect. You can contact me at this email or by phone. And this concludes my presentation. I'm happy to answer any questions that you may have during the Q&A portion of this session. Thank you very much.